we're going to talk a little bit about how our technology works.
Sounds great.
All right, so let's just dive right in. How does our technology work?
So how do we get from 4 sensors on the patient to cardiac output on the machine? Okay, well that's a pretty straightforward question.
Love it.
First of all, it's both very elegant and very simple at the same time. So it's simple to apply and simple to use. It's literally 4 sensors that you place on the chest surrounding the heart and the great vessels. You want to create an electrical field around the chest. What we do with those sensors is we instill a very small high-frequency electrical current, and then we watch as that current comes back to the sensors, and we look at the changes in those currents. So we're creating this electrical field and looking at the changes. It's a little bit similar to ultrasound in that if you think about ultrasound, you apply ultrasound waves, watch them bounce back, and see how they change as they come back. Same sort of principle, only with electrical activity. And so that electrical activity changes in a couple of ways. It changes both in the amplitude, the height of the waveform will change a little bit, and then the timing of that wave changes. Our special sauce is in the timing of that wave, because that's where we look. And the main thing that causes a difference in the timing is the amount of red cells, the amount of blood volume in that box.
Okay.
So if you think about it, with the cardiac cycle, the main thing that's changing in here during the cardiac cycle, which is where we're looking, is between systole and diastole, there's different blood volume in the chest. That, of course, the volume leaving the box would be the stroke volume.
Okay.
So we take that electrical signal, and we have looked in over 65,000 patient samples and correlated that to very well-executed, tightly controlled thermodilution to arrive at stroke volume.
Okay.
That's how we do it. And so, in essence, we're looking at the electrical signal change that is correlated to the blood volume that leaves the chest with each heartbeat, which, of course, is stroke volume.
I like that. Talk to me about some of the advantages of using this technology.
Well, I think one of the core advantages of using this technology is that it's very easy to use. Okay. So literally by placing sensors on the chest, you can hook up and have a cardiac output within minutes. The other thing I think that is a core advantage of this too is we measure centrally. So we're looking at the blood volume leaving the chest directly at the chest. We're not looking at arterial waveforms peripherally or other things that can be distorted from the chest out to wherever it is that you're measuring. So we measure centrally. I think those are the 2 really sort of core advantages of the technology.
Okay, so I don't need an art line.
No,
okay.
Absolutely not. The other thing is with this, since we're not arterial waveform based and not respiratory based, we measure through dysrhythmias, any type of changes in the cardiac cycle we catch. We'll show you what the actual cardiac output is through those episodes.
So AFib.
AFib works fine.
Okay,
Yeah.
all right. So then conversely, talk to me a little bit about what some of the limitations are.
Sure. It's a great question. I think, as I said, we create a box around the great vessels in the heart, and we look at everything leaving that box as cardiac output, as forward flow. There are some situations where you have backwards flow out of the heart. We would certainly see that as forward flow, so in those situations, we potentially would overestimate cardiac output. Likewise, if there are intracardiac shunts that are occurring, we see blood leaving the chest, not necessarily the circulating blood volume. So depending on how you're measuring it, is important for comparisons.
Okay. So here's another question for you. Let's talk about accuracy. I know we mentioned a little bit about thermodilution, but can you talk to me a little bit more about how really accurate is this?
Sure. Well, I think one of the things to make sure that we differentiate, when people say accuracy, they usually mean a couple of different things. One is the ability to compare it to a gold standard, so 2 technologies and how closely they compare. And then the other thing is that with repeated measurements, how likely are you to get the same measurement? So, a ruler, for instance, is very precise. If you take a ruler and you're measuring for 10 inches against something, every time you apply that, you should come up with very close to 10 inches. So that's precision.
Okay.
So accuracy against a gold standard, first of all, that begs the question is, what's a gold standard?
Sure.
Okay, and so the gold standard in clinical use is often the Swan-Ganz catheter. And a lot of us have grown up with Swan-Ganses, certainly I have, and we've become very complacent and sort of understand how a Swan works. We think of that as a gold standard, but the Swan actually has very poor accuracy as well as precision when it's compared. Swan-Ganz, the accuracy is impacted by how the catheter is placed. Is it in the right place? Are you using the right amount of injectate? Is there any tricuspid regurg? There's a whole bunch of things that come into this. Temperature, exactly. All those things come to bear with how accurate the Swan-Ganz is. Likewise, the ability to be precise, so repeated measures.
Sure.
What we do know with the Swan-Ganz is that it can be 15 to 20% differences on measure over measure. In fact, it takes 10 well-done measures to get down to about a 10% variability on the Swan-Ganz. So we tend to forget that in clinical use just because we've gotten used to it. But when we look at the Cheetah technology, okay, and this is tested against aortic flow probe in open chest animals and tests very, very well. We have accuracy against aortic flow probe of about 6%. So our mean bias, our mean difference between aortic flow probe measurements and ours is actually quite good.
Wow, that's good.
Similarly, with precision, the ability to repeat measurements and get the same measure against aortic flow probe is roughly about 6.1%. So from a precision and accuracy perspective, our technology is actually very, very good. Where we get into problems and challenges with clinicians, and clinicians sometimes will question the accuracies when they're comparing against other technologies, which frankly are not as precise and not as accurate as our technology, yet they believe them to be.
Right.
And so we end up challenging a lot of paradigms when it comes to accuracy and precision. But the technology is actually very good. So we've been validated against all of the major technologies, and we're happy to go head-to-head with any of the technologies if need be.
Nice. So we sometimes hear mistrust around all the non-invasive technologies. Why do you think that is?
That's a great question. I think several things come to mind here. I think clinicians are naturally cautious and skeptical, as we should be.
Sure.
So I think that's just in our nature. It's the way we approach the world, which is a good thing for our patients. That's not a bad thing. I think the other thing, though, too, is if you think about it, this is almost magical. You're placing sensors and we're getting a cardiac output.
Right.
I grew up in the days if you had to put in invasive lines, this was a big procedure, and suddenly I can get this off the surface of the chest. How does that work?
Absolutely.
And so I think there's a lack of trying to understand how it is that we do that. And then I think the other thing is that these technologies, we talked about this really being this nice march of technologies. A lot of the earlier technologies on the market had some marked limitations to them. And I don't think we understood them as well. Certainly clinicians didn't. Pulse contours had problems with vascular resistance changes. And so when used in those settings, it becomes less accurate.
Sure.
Echo Doppler has to have the optimal signal. If you don't, it becomes less accurate. So there are ways these technologies become slightly less accurate. And if you're taking them outside of their ranges and their ability to execute there, you'll be disappointed in that. So I think there's been, it's been a variety of things. The nice thing about bioreactance is that those limitations don't exist. We measure centrally, so we're not impacted by vascular resistance changes or changes in an arterial line. We aren't impacted by respiratory changes. We're not impacted by dysrhythmias. So all of those things, our technology is very robust and has the ability to play through all of those.